Good morning, everyone. Thank you very much for inviting me to this conference. It is a privilege to me have the opportunity to be here in this setting. So thank you, Carl, thank you, Fiona, thank you for Center for Evidence-Based Medicine. First of all, I had to be explicit with respect to the point of view of my presentation. I'm a clinician, I'm a cardiologist, I'm equally committed to research and to teaching critical appraisal skills in the national Spanish health system. Having said that, I'm going to talk about the role of critical appraisal in knowledge translation, about regarding the critical appraisal as meeting point between writers and readers, the current state of writing and reading, and finally, other challenges for the future of the critical appraisal. Let's start with the first point. Critical appraisal of evidence involves reading and interpretation, as you know, and the interpretation is crucial for consumers of research when deciding whether the results are believable and transferable, whether the further research, policy, education, or clinical practice. To describe more in depth the role of critical appraisal in knowledge translation, I'm going to use the scheme of Pathman, the well-known as adherence, awareness-to-adherence model, described by Pathman and popularized by Paul Gracieux. You can see the pipeline, there is three areas, respectively, the patient education, the quality improvement, and the side, the EVM, the more clinical decision related. The three areas are absolutely related to the critical appraisal. In the three areas, it's absolutely imprescindible they use. Of course, the critical appraisal is the classical skill in the 5 cycle of EVM, of formulating and squarable questions, searching for the evidence, critical appraisal, applying the evidence, and assessing the performance of clinician. But there is some nuance in the critical appraisal which are different whether the sources of evidence we are using. For example, if we are using studies to answer our question, we are using the critical appraisal as a tool for making health decisions. However, if we are using the synthesis in our work, there are two levels of critical appraisal. A first level, in which the critical appraisal is a tool for assessing the quality of the primary studies included in systematic review. And a second level, in which the critical appraisal is a tool for making health decisions, to decide if this systematic review will be incorporated or this evidence will be applied to our patients. Regarding the synopsis, either the studies or synopsis of synthesis, the problem is quite different. Because in the synopsis, the reader has not direct access to the article. So we can make a critical appraisal of the synopsis. Similarly, the summaries, the reader has not access to the critical appraisal. Sorry. I said the reader has not access to the article. So we have two options. We have to be confident in the sources of evidence in a similar way that when we are choosing our favorite newspaper, or define explicit criteria to assess the sources of evidence, the summaries or the sources of synopsis. In any case, it's clear the critical appraisal is present in all the process of EVM, Sorry. Okay. But it's present in all the process of CVM with different purposes. Critical appraisal may be used for informing decision, clinical or at different levels. Critical appraisal may be used when doing a systematic review. In this case, we are using a research tool. And finally, critical, we can, but for synopsis and summaries, it's not possible to do a critical appraisal sensu stricto, but it's possible a critical judgment when we are selecting the appraised evidence. In this case, we have to look at the selection, the critical appraisal, the process of critical appraisal, the synthesis, the publication, and the updating these sources of appraised evidence. So, we can see the critical appraisal is present in all the process of EVM. Can be seen is the cement that binds all the EVM processes. And it's the cement that binds all the EVM processes because it's the meeting point between the evidence and the scissors. It's the meeting point between the text and the reader, the meeting point between the evidence and the user or doer of evidence. Okay. Well, critical appraisal is basically a special type of reading. Hereafter, we are going to concentrate on this, but please let me first spend a few minutes in drawing a brief description of the reading in general. Classically, the text in the reading is a fixed element. There is a lot of effort in the editorial, in the editors, and a lot of tradition in preserving the text as immutable. But the reader, the first characteristic is immutable. The reader, really the effect or the objective of the reading is to change anyway the mind of the reader. The second characteristic is the reader has preconceptions. The reader, when arrived to the text, has not in blank the mind. So there is some preconception or prejudices in the reader. And the third characteristic is an individual activity, but this is depending on different cultures, on different epochs or areas. For example, the tradition of to read individually in the West has 200 or 300 years only. Okay. I would like to look at the preconception of prejudices we have talked about previously. There is different type of preconception of prejudices. The first is the cultural approach. There is different perception of the values in the societies, and the health is perceived as value. For example, everybody knows that the chicken soup is good for health. Or for example, in Spain, the bread and red wine is good for children. Or everybody knows in Scotland, a little bit of whiskey is healthy. So we have preconception, cultural preconception with respect to the health. Very clinical legends and clinical traditions, because this is the clinician in the room, know perfectly that there is many questions and many activities only justified by the tradition. The third type of preconception or prejudices is the mechanisms and the schemes of functioning. For example, the concept of homeostasis, the feedback in endocrinology, and many other concepts, which is a scheme of functioning and it may be seen as classical paradigms. The fourth type of preconception is the background knowledge, including the body of evidence, but everybody, when they arrive to a new text, have a lot of knowledge, particularly in the health professions. And finally, the fifth type of prejudices is the methodological or epistemological, which is related with the quality of research. most of the EVM courses are focused on training in methodological and epistemological aspect, in other words, including the prejudices in the mind of the students. Classically, the critical appraisal focuses on material and methods. That is to say, about the prejudices number 5, the prejudices of the 5th category. But less important is they have for critical appraisal the introduction and the order and the discussion. And there is a natural, essential tension between the new knowledge included in material and methods and result, and the old knowledge on the questions that are known included in the introduction and discussion. An example. For example, the oxygen is a positive cultural value, a positive cultural value. This is a lot of metaphors related with the oxygen. There is a clinical tradition for giving oxygen to a patient with acute myocardial infarction, for example. There is a lot of mechanisms and schemes of functioning that allow and suggest the oxygen can be or may be useful for patients with acute myocardial infarction. Even the guideline, all the clinical guideline of 2009 recommended the use of oxygen for patients with acute myocardial infarction. Well, the methodological, epistemological aspect is perhaps different. In 2010, a Cochrane Review of the Oxygen in Acute Myocardial Infarction, this is the author conclusions. The evidence available is suggestive of harm, but lacks power, so is called due to chance. Current evidence neither supports nor the need refutes the routine use of oxygen in patients with acute myocardial infarction. There is a tension between the traditions and the new knowledge, the new knowledge with the more strong methodology known at the moment. Please, assuming the oxygen review is well conducted, would you first continue to give oxygen routinely to patients with acute myocardial infarction? Only give oxygen to patients with an acute myocardial infarction if there were another indication. Please, could you vote? Please vote. Okay. Well, %50 yes and 70% no. Right. Interesting. Well, the same day in which the systematic review was published, 2 editorials appeared the one in the British Medical Journal. This is, should the oxygen be given in myocardial infarction? And the editorial is said, on the basis of physiological reasons and no trial evidence of harm, yes. And the editorialist of Cochrane Library, in the meantime, those who adhere to the advice to before do no harm, would be advised to avoid oxygen in patients with acute myocardial infarction, unless the patient has demonstrably low oxygen levels and then only delivers sufficient to avoid hyperoxia. It is very clear that this author is using another information from other Cochrane review about the hyperoxia and the hyperbaric oxygen. But this is I'm not interested in introducing in the polemic or in the controversial. To me, the only important is with the same evidence, we can make different interpretations. Different interpretation because probably, in my opinion, the different authors are managing the different type of prejudices in different way. Probably for the BMJ editorialist, the tradition and the mechanisms and physiopathology is more important, and probably for the Cochrane editorialist, is most important the methodology and the other prejudices. So we have to identify the methods to complement the two options, the two problems within the critical appraisal. In any case, the interpretation is not an occasional post-facto supplement to understanding. Rather, understanding is always interpretation, and hence the interpretation is the explicit form of understanding. So, what are the tools for improve or for help us to interpreting the article? There are in the two parts, in the part of the text, in the written, and in the part of the reading. In the written, the new advantages, a lot of work has been made, a lot of uniform requirement of editor, bioethical, methodological, conventions, randomized control trial register, and so forth. A lot of effort. It's a very, very important progress in the last 2 decades. In addition, there is a very important activity, very important contribution related to how the research should be reported. This is well, I'm going to consort extension. It's very difficult to read this slide, isn't it? It's very difficult. Yeah. Consort extension, trend, star, prisma, chord, square, strobe, and well known. And this is compiled in the equator.network. Thank you, Douglas, for doing this for us. Well, with respect to the reading, the question is quite different. Probably the most important question is to choose an appropriate critical appraisal tool. This is important. It's an important component of evidence-based practice. It's a crucial decision when undertaking systematic reviews, and is central to the process of creating appraisal evidence. There are 2 systematic reviews of the critical appraisal tools. One is the 2004, and the other is more recent. It's in the 2011, and I'm going to show briefly. The objective is to evaluate the process of critical appraisal tool development. The inclusion criteria were published in peer-reviewed journal, English language, primary or synthesis studies. Exclusion criteria, diagnostic studies, economic evaluation, and clinical guidelines. Well, finally, they selected 44 studies. This is the scheme of the studies in different decades. In the 1980s, 7 tools were published. In the 1990s, 14 studies were published, and in the current century, 23 studies. This is an indicator of a progressive interest in these topics. The tools were developed using different techniques, expert, Delphi methods, evidence from literature, nominal group techniques, and so forth. And different options were used for item construction, and different techniques were used for item selection, not necessarily evidence-based. With respect to the type of design, as usual, the experimental studies were more investigated, 11 studies, systematic review 4, 2 quasi-experimental studies, 2 cohort studies, and single subject design, obviously 1 single. With respect to the reliability, the more remarkable of this slide is 70% of the studies reliability was not tested. And with respect to validation, 25 of studies not mention the validation process, and 59 only performed a content validity study. So, well, because the data don't speak themselves, we have to interpret this data. My interpretation is important. This is critical appraisal. Important issues were excluded. For example, McMaster, Oxford, CAS Spain, GATE, and so forth. Well-known tools, very used for the teaching, was excluded in the systematic review. The language exclusion is absolutely crucial for countries, non-English countries, for example, Spain. Very remarkable, the Cochrane handbook, in which it contained the tool for assessing the risk, is excluded in this systematic review. But we have learned of this systematic review that although the critical appraisal tools are used to assess the validity and reliability of research in the different settings, in the clinics, in the pre-appraisal evidence, in different places, tools themselves have not been adequately validated. Other reflection, there are tools for different purposes. Perhaps the tool for research should be different of the tools for application or the tool for teaching. And probably the system of evaluation is probably different for each of these tools. Well, going on to the last, to the fourth point. This is again the equator slide. Well, it's better. It's more readable. It's more understandable. The cognitive load is less. It's just, sorry. Well, I have played a little game with the methodological convention for reporting a study. This is called continua scripture, and was used in the Greeks and all Roman. Just was used until the 2nd century after Christ. This is interesting because this scripture is usually was read aloud by others, and when the scripture is read, the cognitive burden is less. The introduction of separation between words reduces the cognitive strain involved in interpreting the text, making it possible to read quietly and silently. The previous tradition is read aloud, and gave us other advantages, such as the liberation of the scribes, and in some way producing a democratization of the reading. Nevertheless, the few books available maintained the reading as a collective task. And only many years later, when the invention of printing press, did the reading turn into a basically private activity. So the two examples are to show how the change in writing are able to produce a change in reading. And some authors suggest that not only change in reading, but also changes in the way of understanding. This is probably excessive. Anyway, the recent change in the reading are not only change from the page to the screen. The change in the screen, but change in the medium. I'm going to use this sentence of this quote of Marshall McLuhan to show the change in the message and in the medium. In the message, the text becomes dynamic at the moment. Okay, dynamic, there is a new change. With respect to the medium, it's clearly the screen is completely different in the scrolling, the hypertext, the pop-ups, and so forth. We have to investigate what is the role of this, or impact of this media, this change in the media about the critical appraisal, because there are different types of reading. Reading perhaps with very fast and reading more slow. So I'm going to comment the three challenges for the future. The first is developing techniques to read the background and integrate it with other classical sections of critical appraisal. The second is improving the critical appraisal tools. And the third challenge for the future is managing the cognitive load for readers. Thank you very much.
Can I just quickly ask you, I mean, people often, critical appraisal means reading effectively, and there are lots of tools there seem to be loads of tools for reading and interpreting, but perhaps less effort being put into improving the way people write to make it easier for critical appraisal. I mean, you mentioned, well, all those guidelines, but those guidelines also suffer from relatively high awareness but low adoption. So do you think there should be more effort into improving readability? In other words, aimed at writers rather than helping readers?
Well, I think there is different consequences. I think the critical appraisal, the tools for critical appraisal may improve the readability of the studies, particularly if they are combined with new technologies and new help. But probably there is different type of critical appraisal in applying the evidence. In my opinion, it's different read for applying the evidence, the pre-appraisal evidence, when you are near the death of the patient. And it's quite different, the critical appraisal of the journal club or the critical appraisal tools when you are performing a systematic review. But probably they incorporate new media, new cognitive tools may be useful in my opinion.
Thank you.